trocars P1 to P5 are inserted at the beginning of the operation. In this particular case, in a patient with a neoplasm of the cecum, the presence of large lymph nodes in the superior mesenteric and middle colic vessels was observed, requiring an extensive lymphadenectomy with total incision of the right mesocolon. In thinner patients, such as in this case, it is possible to see the duodenum and the head of the pancreas above them. After the section of the ileocolic vessels, the retroperitoneal dissection continues over the anterior wall of the duodenum. During this dissection, the right colic vessels can be observed in most cases, which are located transversely over the second portion of the duodenum. To approach the middle colic vessels safely, we need to initially access the omental bursa by an incision in the transverse mesocolon. A good exposure is obtained by a P4 traction close to the left branch of the middle colic. For the best exposure of the peritoneum below the ileocecal region, it is necessary to change the operating table to the Trendelenburg position and to reposition the transverse colon over the liver. Next, the cecal appendix should be identified and pulled upwards by clamp P3. The appropriate exposure triangle is obtained by traction of the terminal ileum at 10 cm from the ileocecal valve by P4 towards the patient's left shoulder. For the anastomosis, the two bowel segments are brought together by traction of clamps P2 and P3. A fixation stitch is placed and pulled up by P3.